Thank you, Chairman. Hello, everyone. I'm Lucy Yoon, Yonsei University, Seoul, Korea. I'm very honored to share my talk with all of you here today. My talk is how to evaluate RV dysfunction in pulmonary arterial hypertension patients. I'd like to mostly focus on echo. I have no disclosures. Already, all the previous speakers mentioned, pulmonary arterial hypertension is a progressive disorder defined by the presence of increased mean pulmonary artery pressure greater than 20 millimeter mercury. Despite of current advances in clinical management and therapies, still pulmonary arterial hypertension patients remain suffering from debilitating symptoms with high mortality. And right ventricular performances determine the clinical outcomes of pulmonary arterial hypertension. That's why RV functional assessment is important. However, the indicators of RV dysfunction and their relationship with the disease severity of pulmonary arterial hypertension remain to be defined. So far, echo informed to find pulmonary arterial hypertension. TR peak velocity of continuous wave Doppler measurement greater than 2.5 meter per sec, and RV and RA size and pressure change, and pulmonary artery size and flow acceleration, etc. As we know, RV geometry is quite complex, like the three-dimensional reconstructions of the RV illustration. RV remodeling in diseased hearts can result in profound shape change with RV dilation caused by chronic volume or pressure overload. This is the RV pressure volume loops obtained by a conductance catheter. Loop A depicts a normal RV pressure volume loop. A lower proportion of RV stroke work goes to pressure generation, with a higher proportion going to blood momentum. In the normal state, there is relative absence of RV isovolumic periods. The high momentum of blood ejecting from the RV into the low pressure pulmonary circulation results in continued RV ejection after LV systolic ejection has ended into RV relaxation. Loop B represents a compensated chronically hypertensive RV, and C obtained from a decompensated hypertensive RV, much larger volume overloaded. And we can apply RV pressure overload to pulmonary arterial hypertension and RV volume overload to shunt disease like ASD and valvular regurgitation TR pulmonary insufficiency. Over time, with progressive pulmonary hypertension with this red mark, when a decrease in pulmonary arterial pressure may be a sign of low cardiac output and severe right ventricular dysfunction. In terms of right ventricular dysfunction, let's remind especially ASD, Epstein anomaly, corrected TGA, and single ventricle physiology, etc. And let's think about most common parameters for RV functional assessment by echo. First, TAPSC, tricuspid annular plane systolic excursion. This reflects most important RV systolic functional assessment. And RV volume and size are important. And additional measures include RV fractional area change less than 35% and RV tissue Doppler S prime velocity less than 10 centimeter per sec at the plane of the tricuspid annulus, and RV free wall strain greater than minus 20% likely to be abnormal. More of TAPSC, tricuspid annular plane systolic excursion, longitudinal shortening of the RV reflects the systolic motion of a single point of tricuspid annulus, disregarding the mid-apical and free wall segments. And easy to obtain for visualization of RV lateral wall tricuspid annulus, reproducible, and high specificity and negative predictive power for detecting abnormal RV systolic function. TAPSC is a reliable predictor of prognosis in pulmonary arterial hypertension when TAPSC is less than 17 millimeter, which informs to predict increased mortality. But TAPSC has some limitation for the pulmonary hypertension. Even if TAPSC is normal, RV systolic function can be significantly impaired in severe pulmonary hypertension. And motion of tracheovalvular annulus is affected by prior cardiac surgery, for TAPSE is less useful. And regional RV hypokinesia as well. Recently, TAPSE and pulmonary artery systolic pressure relationship has been regarded a helpful parameter. The normal TAPSE of red dot here, the lower pulmonary artery pressure noticed. But the lower TAPSE, the higher pulmonary artery pressure by this indirect estimation of TI measured pressure. Also, the ratio of TAPSE to pulmonary artery systolic pressure is a non-invasive surrogate indicator of RV pulmonary artery coupling for clinical application. TAPSE and pulmonary artery systolic pressure provide information on RV diastolic stiffness. This is very important information. IVC diameter and collapse pattern with respiratory variation also helps to estimate RA pressure and RV status in pulmonary hypertension. Of course, catheterization helps for RV assessment with standard catheterization and diastolic pressure and peak systolic pressure, thermodilution for cardiac output and stroke volume, high fidelity micromanometer, DPDT, conductance catheter, RV elastance and stiffness, important, stroke work and RV power, and intracardiac echo for dimension and function. Also, many other hemodynamic assessment is possible with calculation. RA pressure and CVP, right-left discordance of filling pressure with pulmonary capillary wedge pressure, pulmonary artery pulsatility index, RV stroke work index, pulmonary vascular resistance, and pulmonary artery compliance, all can be calculated. In pulmonary hypertension, RV enlargement looks like this geometrical change compared to LV. We notice this RV enlargement with apical deformations around LV apex and RV to LV ratio greater than 1. So let's think about what happens to RV in pulmonary hypertension. This is a very nice illustration of the consequence of pulmonary hypertension for the right ventricle. Initially, coupling of the RV to the pulmonary artery, the high arterial load is maintained by RV adaptation with increasing contractility and wall thickness. This is coupling, but subsequently followed by RV dilation and finally uncoupling, which results in reduced cardiac output with high metabolic demand, uncoupled state. This is MRI pictures of RV volume changes. Left is maintained coupling state, but right side, we can notice very huge enlarged RV, uncoupled state. Volume increased, high metabolic demand, and reduced cardiac output. So this RV is very inefficient. Having remembered all together, by combining imaging and invasive modalities, cardiac catheterization and cardiac MRI, a full physiologic assessment of the load of pulmonary circulation and right ventricular function can be derived. Now, I will share some cases. First, 21-year-old female patient came to the clinic, has ASD bidirectional shunt, and TR severe, huge RA-RV enlargement with volume load and suprasystemic pressure load RV. Yes, it's moving. Severe TI pressure measured almost 140 millimeter mercury with RA-RV enlargement. And RV fractional area changed 23%, which is less than 35, and TAPSE 20 millimeter measure, which is larger than 17. So how is this RV? Pitch Doppler S prime at tricuspid annulus measured 14.6, which is larger than 10. Compared to normal RV strain curve left side, this patient's strain measures were all decreased at the RV free wall. And short pulmonary acceleration time we can notice. So how is this patient's RV function? RV to pulmonary artery well coupling state or uncoupled? We discussed this patient's RV function is not ready for the ASD closure yet. So treat and repair strategy had been applied for this patient. And finally, we closed our ASD with fenestrated occluder. Then 1 year follow-up after repair, her RV changed much smaller and the longitudinal strain shows much better function. Happy case. The other groups published data demonstrated 1 month after ASD closure, RA and RV size decreased, pulmonary artery pressure decreased, APSC increased, and myocardial performance index and longitudinal strain increased. All implied RV function got better with treatment. The second case of 29-year-old woman with ASD bidirectional shunt. Her TR is very severe with pressure more than 150 millimeter mercury, and APSC shows within a normal range, but RV function is questionable. Severe pulmonary hypertension with marked dilated pulmonary artery size here, and also pulmonary acceleration time is very short. Her CT showed really severe pulmonary vascular obstructive disease pattern with huge pulmonary arteries here. Her IVC plethora 22 millimeter and right heart catheterization with balloon occlusion test. All the data confirm severe pulmonary hypertension and RV pressure overloaded state. For this patient, pulmonary hypertension treatment should be prior to preceded. So having summarized all these, not just RV dysfunctional assessment, we would like to clarify the RV pulmonary artery coupling or uncoupled state of RV dysfunction, which informs us to provide what kind of treatment is optimal. So we should look at TR, RA, RV size, APSC how much, tissue Doppler velocity, and RV free wall strain, pulmonary artery size, IV size and flow pattern, and catheterization and other modalities of CT, MRI, nuclear scan, etc. My conclusion is RV function is an independent predictor of cardiovascular morbidity and mortality in patients with congenital heart disease and pulmonary artery hypertension. The assessment of RV function is challenging due to complex RV morphology, but if suitable to decide the relevant modality of treatment, important to define the RV dysfunction to understand RV pulmonary artery coupling and uncoupled condition. And right heart catheterization is often required to confirm the diagnosis, and if necessary, integration of available multimodality imaging must be performed. Thank you so much. And I'd like to invite all of you to the second Asia Pacific Society of ACHD Symposium upcoming October 16th. Registration is available till October 10th for free for everybody. And this is the website you can register. So I'm happy to invite all of you, and I'm very much looking forward to seeing you all then. Thank you so much again.